Hi, everyone. Thanks for joining us. My name's Martha Duncan. I'm with the Clinical Coordinating Department with the Energy Oncology Operations Office. We support and answer questions for the BR008 protocol. Thanks for joining this webinar. We're excited that you're able to join us and anxious and curious to hear what your comments are and if the recent amendments have helped. Having said that, I'll hand it over to Dr. Mitchell, who's one of the PIs on the protocol.
Well, again, thank you so much for joining us this morning. I guess it's still morning most places. I'm just going to share my screen here. Can you all see that okay? Okay, perfect. So again, thank you so much for joining to talk today about the BR008 or HERO trial. It's a phase 3 randomized trial looking at radiotherapy optimization, really radiation omission for low-risk HER2-positive cancer. And I'm helping to lead this alongside Leora Bronstein and super excited about the potential this has to impact quality of life and breast cancer care for patients worldwide. It's not just us. There's a ton of people, I'm sure I don't have some of them listed here, that have helped to get this trial up and running. And as many of you may know, we've been struggling a little bit with accrual, and so we'd hate to not have all this hard work lead to an ultimate result. So thank you all if you have the trial open, and if you've seen the amendments, we'll talk about those today. But just by show of hands, how many people have the trial open that are on the call? So it looks like majority of people on. Anyone not have it open? And today's the day where we're like trying to convince you, like, let's join this study. Guess I probably asked that too soon. Hard for people to put their hands down, but has anyone seen at least 5 eligible patients since the study's been open? A few new hands pop up, maybe. And I know we're keeping track of who's enrolling patients. I know it's been historically pretty hard because the population's been small, but as Martha mentioned, we do have some amendments went through. I'm going to go a little bit backwards here and just start real quick with the amendments for the people that are on that really just want to know the amendments. And then we'll go through the rationale and things that we're still working on to try to improve accrual. But in general, goal was to open this up as broadly as possible so that we're not missing anyone that could potentially benefit from radiation emission. In our own personal institutional trials in this space, we did have age lowered during the time that we had our trial open, because we noticed there are a lot of people in their 30s who had a path CR and did great, and so we wanted to be able to offer the study to them. So now the trial is open for women as young as 18 years old. And then size criteria, we've also expanded. So now if you go to surgery first and the tumor is 2.3 centimeters, that's okay. You can still enroll. It's up to 3 centimeters now for those patients who have surgery first. And for those patients who go to chemo first, they just need to be less than 5 centimeters. So T2 tumors there. And then previously we had some people on these calls saying, oh, you know, our providers like to offer Kadcyla or TDM1 because that means the patient doesn't lose their hair. And so now we have that as an option. So if your institution doesn't use the TH or TCHP or whatever it is, and they want to use ADC monotherapy, that's totally fine now. And then finally, we had some patients where the tumor was gone when they went to surgery, the chemotherapy worked, but they had a little bit of the precancerous DCIS still in the specimen, and so we're allowing those patients as well now. So really trying to broaden the patients who are eligible. So just moving into why we're doing this study, why eliminate radiation. You know, when I was first in practice, everyone got 6 weeks of radiation therapy. Their breasts were red. It was terrible. It was awful. But these days, we're really good at like saying radiation's no big deal. But even with all of the advancements, you know, patients are still having to take time off work, 3 to 4 weeks, if you live really far from a radiation center, or if you're in another country and you have limited resources. That can be really difficult for patients. Secondary malignancy is still a thing. So even when you give really small doses of radiation therapy, and as a provider, when you're in practice long enough, you see someone where you've caused them to have a cancer that they wouldn't have had, that maybe that one's not the curable one, right? So if we can reduce that risk by not doing radiation at all, that's fantastic. Breast edema, again, not super common, maybe 1 to 2% of patients, but when it happens, it's frustrating. Their breast feels heavy and swollen, like when you've just had a baby and your milk comes in, right? It's not a comfortable thing to have that all day, every day, and they have to wear compression bras and their clothes don't fit. There's also tissue fibrosis. Sometimes patients have just rock hard breast. Again, it's like 1% of patients. It's not huge, but it happens. They have contracture again. Clothes don't fit right. It's painful. It's not something that you want if you can avoid it. People always read on the Cancer Society website, oh, if you've had radiation, you can't have reconstruction in the future. And there are some caveats there, but in general, when we give radiation, it does limit what you can do future-wise in terms of that surgery. For our darker pigmented patients, so our African American patients, our Indian patients, sometimes their tanning from the radiation doesn't go away. So they just have permanently darkened skin over that breast, and it's not something they're super happy about. During treatment, patients can get blistering of the skin. On the left side, we worry about heart disease. Although rare, sometimes we see lung disease, even when we have really early stage patients where we're trying to avoid the lung altogether. Rib fractures happen in 1 out of 200 patients. So there's a long list of things that still happen even with the improvements in radiation therapy and smaller treatment fields and all of this. And of course, there's also the cost, right? So it's not cheap to go through radiation therapy. And even though insurance often covers it, there's still copays and other things to deal with. Time off work, again, contributes to that financial loss. Surgery, people have talked about why not get rid of surgery instead of radiation. There you have, anesthesia and scar, but it's a 1-day procedure. Most patients would prefer to have the tumor out. And just in general, in terms of radiation therapy, we used to get this a lot more in our clinic when people would say, oh, isn't radiation the gift that keeps on giving? So again, a lot of these side effects that I've listed in red are things that are lifelong after a patient's had radiation. Here's just some examples of that, right? So this patient on the left, they got just standard whole breast radiation therapy. And so during treatment, they got really blistered skin and the inner part of the breast. And then long-term, there's telangiectasias that come, and those are permanent scarring. They try to wear a V-cut swimsuit. It's not going to look great because they got those scar tissue there. And then on the right is a patient who had super low dose radiation therapy, just had a little bit of radiation that went into the lungs from a little boost from electrons, just 2 gray, which should not, by all the models that we have, cause pneumonitis. But this is a patient who had symptomatic pneumonitis, had to be on steroids for 6 months, despite having very minimal radiation therapy. So again, we know that even with today's modern radiation therapy, and though the great majority of patients do well, if we can find those patients that don't need radiation at all, that would be fantastic. And we know that not everyone needs it. So even dating back to the early studies of lumpectomy alone versus lumpectomy and radiation with the NSABP-B06 trial, risk of recurrence without radiation was high, 40%. But that also means 60% of patients did great. They didn't need the radiation therapy. And so now in the modern era, our goal is figure out who are those people that don't need it versus who are the people here in blue who really do need a radiation, where it's going to make sure that they get their disease cured. And then furthermore, who are the people that even with radiation, we need more, right? So hopefully in the next decade or two, we'll do a better job of really tailoring our treatments per patient. And this is not a new concept to get rid of radiation therapy. It's something people have been thinking about for a long time. Back in the 90s, the CLGB study was opened. It looked at patients who they thought were really low risk based on age. So if you were over 70 with a small hormone positive tumor, you could go on this trial. This before we had things like sentinel node biopsies, so we don't know what was happening in their lymph nodes. And despite that, the risk of recurrence was really low, 10% at 10 years. And though radiation reduced it, went from 10% to 2%, there was no impact on survival because if these patients had a tumor come back, we were able to find it quickly, treat it, and still cure those patients. So that's the thought here too. You're putting a patient on trial and we can't say for sure what is that risk of recurrence, but we know if it comes back, we're probably still going to be able to treat it and cure it. So it shouldn't impact their survival. But again, that's why we're doing the trial to prove our hypothesis. And really HER2 positive breast cancer, there's some physicians out there that might say, oh gosh, HER2, that's like the worst subtype out there. I don't want to put patients who are HER2 positive on any trial where they de-escalate therapy. And so I always like to point out this is an older trial where patients with HER2 positive, triple negative, or hormone positive breast cancer were just treated with surgery and not any sort of systemic therapy. And they were really early T1A, T1B. And you can see the HER2 positive before HER2 therapy was out. They did not so well, right? Worse than the triple negative versus in the modern era. So this is the same sort of graph from patients treated on the APT trial, which is a study of T1N0 breast cancers where they received just Taxol Herceptin, and they did great. There were 2 recurrences out of almost 300 patients who got lumpectomy and radiation therapy, so less than 1% local regional recurrence. And it's not that they had better radiation or better surgery, it's because they had that HER2-directed therapy. So that targeted therapy is really what's improving the cure rate in this population. It's not our local therapy. There's also some suggestion that the HER2 positive patients don't even respond to radiation the same way that other patients do and with the other tumor subtypes. So this was a study from Sweden where they looked at lumpectomy alone versus lumpectomy and radiation therapy. And small numbers, so hard to say for sure, but certainly there was some suggestion that while the hormone positive, here the luminal A, luminal B, and then the triple negative, when you had no radiation in yellow versus radiation in blue, the radiation definitely reduced that risk of recurrence, but they didn't see that same impact with the HER2 positive breast cancers. So kind of in summary from all this, in the modern era, HER2 positive breast cancer patients have super low rates. The risk of recurrence with lumpectomy radiation is lower than those older hormone positive patients for whom we've been routinely offering emission of radiation for years. And the reason that their recurrence rates are low is because they have really effective systemic therapy, nothing to do with how we're doing radiation these days. And again, there's some studies suggesting HER2 positive breast cancers don't even respond that much to radiation. So the reason I got really interested in this topic, I would have patients that came into my clinic who had HER2 positive breast cancer. They got the chemotherapy, they went to surgery, they came to see me after the lumpectomy, and they're like, what on earth are you radiating? Like the tumor was gone, the surgeon cut everything out. Like, why am I doing this? And I would just say, well, we have to because we've never asked the question, what happens when we don't radiate? And so that inspired me to say, hey, we should ask that question for those patients that are wondering what's the answer to this question. And I have been passionate about the chemo first arm, but certainly I know every institution's different. But if your institution's one of those where you always give the Herceptin-based therapy before surgery, that's a great way to know if the patient's going to respond, right? If they've responded to that HER2 therapy, if everything's gone, you can feel pretty confident that all this local therapy is probably in excess. So I really like the neoadjuvant arm for that reason. Another study that's shown to us that that's the case is the recently presented B51 trial. So this was a study looking at patients who had node positive breast cancer who were given neoadjuvant chemotherapy. And if their nodes cleared with the therapy when they went to surgery, the nodes were gone, those patients were randomized to radiation versus not in the nodes. And while there may be just a few extra events in the patients who didn't have radiation therapy, in terms of the actual survival, disease-free survival, all those other big oncologic outcomes, absolutely no difference. You can see here 5-year overall survival, 94% for the patients without radiation versus 93.6 for those who had radiation therapy, really suggesting in those patients where the chemotherapy does what it's supposed to do, we're probably just adding toxicity with the radiation therapy. This is just another study from here at my institution, MD Anderson, again suggesting that for those patients who have a great response, even really advanced disease, this included patients who were like inflammatory and nodes positive in the supercloud region, et cetera, they had very low rates of local recurrence if that chemotherapy worked. And then our institutional clinical trial looking at patients in the space, again, where they got the chemotherapy, everything melted away. They had lumpectomy, nothing found. We published on our first 6 patients as part of a planned subset analysis. We'll hopefully be able to publish on the whole cohort of 30 patients here in the next few months. We'll have 24-month follow-up soon. But really great outcomes. We're not seeing recurrences in these patients, even if they don't have the radiation therapy. So again, these patients have really low rates of recurrence. Retrospective studies show there's minimal impact of radiation anyway on the HER2 subtype. And in patients who have a path CR, there really seems to be limited benefit of radiation therapy with some of these studies that we have. So that's why we're really excited about this trial. Again, trying to figure out how we can get more patients enrolled. We did do a survey a while back asking what was the difficulty in getting patients enrolled. Certainly, there are some physicians that are hesitant to de-escalate. I get that. Certainly, as I've been working with this trial concept for the last 10 years, I've run across many of those physicians. Some of them say, well, I want to keep it at 99%. I don't want 98%. But, if your institution, you would like Leo or I to come and chat and say why we're passionate, why we really want to see patients enrolled. If you think that'll help for us to chat with your physicians that are kind of hesitant about the trial, we're happy to do that, happy to give them a call. I think we offer that every time, but no one's said that they want us to come present at their tumor board. But please, we're happy to talk to anyone if you think it'll help with your enrollments in terms of getting physicians on board. The other thing is patients are hesitant to de-escalate. Some of that I think is because in the modern era and it's crazy because I remember when I first started, everyone was like, yes, get me out of radiation therapy. But now everyone talks to their friends and like, oh, radiation's no big deal. But again, so it's that healthy balance, right? We have to figure out how to make radiation sound bad enough that you want to be on a study of no radiation. But then you convince them so they're like, oh, I'm just not going to get radiation while they leave your office, right? So it's really difficult, these randomized studies of no radiation therapy. It's a lot of work for the physician. We realize that. But if there's things that we can do in terms of patient materials, if you have ideas of what we can do to help support you all to get these patients on board, we're more than happy to do anything that you think will help. We're going to try to talk to some patient advocacy groups to put some new videos on their websites and things like that to see if that will help as well. Previously, we had a lot of comments that it was too small of a population, so we're hoping these amendments would broaden things out. But certainly, if you feel like the new amendments still aren't making it a broad enough web, let us know. We're happy to help there. We heard before that, again, the systemic therapy was different in institutions. So we've really broadened that. The language of the protocol is such that it should be much more flexible, depending on what you're using at your institution. And same thing with the radiation regimens. It should say suggested now. It doesn't say like recommended or anything. So you can feel comfortable. Whatever you do at your institution in terms of how you radiate your patients, you don't have to change it for the trial. And then there were some other ones that were just random one-offs that we didn't address too much. So again, in terms of the trial amendments, so this is a trial of HER2 positive breast cancer. They have to be early stage, node negative. 2 different ways to get on the study. First way on the left is the adjuvant cohort. Those are patients who go to surgery first. They have a small tumor. It used to be had to be less than 2 centimeters. Now it only has to be less than 3 centimeters. They have to have some sort of axillary assessment, and then they have to have some sort of targeted therapy. So again, the particular systemic therapy regimen is much more flexible than it was in the prior listing of the study. And then the other way to get there is to give the chemotherapy first. Again, more flexibility there. It can be up to 5 centimeters now, so all T2 patients. And again, the systemic therapy is a bit more flexible. And then with the pathologic review, if you see that little bit of DCIS, we're not excluding those patients anymore. And again, the age down to 18. Stratification on the study that new amendment is out. And so hopefully if you have this study open, you should be able to run that through. If you haven't opened yet because you were like, oh, there's not many patients, and you see this and you're like, yay, now there's like a huge amount of patients we can enroll, please enroll. Let your groups know that the amendment has made it so that this is very broad. So it's been out since I think January or so. We just got all the changes in our institution last month. So we're enrolling the broader population now. And then the patients are then randomized to the breast radiation therapy and the HER2 therapy, or just the HER2 therapy alone. And again, stratified based on age, tumor size, estrogen receptor status, and then whether they're on the adjuvant or the neoadjuvant pathway. The primary objective is to compare the recurrence-free interval for those patients randomized to radiation versus not. And we feel that that is going to be a pretty minimal difference between the two. Secondary objectives, lots of things here. We're looking at other oncologic outcomes like ipsilateral breast recurrence, disease-free survival, overall survival. We're also going to be looking at the quality of life, so breast pain, and then also anxiety. So sometimes we worry if patients don't get that radiation, they might panic, wait, what if I had gotten the radiation? Maybe that would reduce my risk. So we're going to be looking at all of those factors as a part of this study, as well as cosmesis, fatigue, skin issues, etc. In terms of the recurrence-free interval, so that's all based on that first graph I showed where the recurrence rates were really low, less than 1% local regional recurrence. That same study showed that the 7-year recurrence-free interval was 97.5%. And so clinically acceptable would be a difference of less than 3.6% for the patients who don't have radiation therapy. I'm hoping to accrue within 5 years. We've kind of adjusted a little bit for that because we've had a pretty slow ramp up, and then there'll be additional follow-up in order to have sufficient time to look for events. So total sample size, we're looking for 1,300 patients. We're at like 70 something. Martha can probably give us the actual numbers. So we're better than we were, but certainly still a bit slow. We're getting around 7 or so patients a month, and we really want to be more at like 15 or so patients a month. Again, have to be 18 years or older, female or male patients. They don't have to be female. And it used to be that, we were pretty strict about the systemic therapy, but now we're a little bit more lax in the regimens, and also say they had a tough time and they only got, 79, so almost 80. So if they only got their 8 weeks and they didn't get that last cycle because of toxicity from the chemotherapy, that's totally fine. If they're in the adjuvant arm, it's fine. And if they're in their neoadjuvant arm, it's fine. So we don't have to stress about that. Again, size-wise, that's changed. So up to 3 centimeters, which was the size on the APT trial, and then the neoadjuvant up to 5 centimeters. If they're in the neoadjuvant arm, we do want some sort of imaging up front just to suggest that they didn't have nodal involvement. In terms of radiation regimens, again, this is no longer says recommendations, it says suggestions. I know there were some institutions that are like, nope, if it says recommendations, we have to go by what the protocol says. And they had radiation oncologists that use different regimens. But now these are just suggested. So if they want to use these, that's great. But if you have a different regimen you use at your institution, that's completely fine. The partial breast still is pretty much limited to those patients who have surgery first, just because we feel like it'd be hard to figure that out in the neoadjuvant setting. But I guess we didn't really say has to be that way. And then in terms of follow-up, so these patients will have history and physical every 6 months for the first 2 years, and then annually, same thing with their breast exam and their adverse event assessment. They'll have cardiac toxicity evaluated every year for the first 5 years. And then in terms of imaging, mammogram or breast MRI is going to be required 1 year post-randomization and then annually. And then we have the quality of life surveys that we give through 5 years. And then there is some optional blood collections, tissue specimen collections that we can talk about. So for those patients who agree to that, they're due at baseline within 90 days of randomization. And for the adjuvant group, those patients, we would want to do the block from their primary breast tumor versus the neoadjuvant would be from that core biopsy that they had at the time of diagnosis. And then for the optional biobanking of blood, it's 3 purple top tubes, again, due at baseline and then at randomization. So we'll be looking at 12, 24, and 72 months with the thought that if we do see recurrences, potentially those are things that we can see with the liquid biopsies. In general, patients are not permitted to participate in other therapeutic trials, although that's been put under question. There's been some suggestion, especially in the neoadjuvant arm, that maybe that's okay. And then we've talked before about having talking points for providers. So if that would be useful for you all to share those, we certainly can. The other thing we'd like to emphasize is if you're able to screen early, that's fantastic. I know not every place has the resource. We fortunately have some other clinical trials in the same space where we're trying to look at everybody with HER2 positive breast cancer at the time of diagnosis and try to message the providers early. Because what happens is a patient, they see their surgeon, the surgeon's like, well, you can have mastectomy or you can have lumpectomy and radiation, and lumpectomy and radiation are married. And so then they get to the time where they're coming in for the radiation consult and they've already got in their head, if I have lumpectomy, I have to radiation. And then we say, oh, but you could avoid radiation. Like, yeah, I've never heard that before. It's the first time. Versus if that first visit you say, wow, you've got HER2 positive breast cancer. That's such a great prognosis. Like these drugs have really transformed HER2 positive breast cancer. It's like the biggest breakthrough in breast cancer in the past century. If you have a good response, you could potentially even skip out on radiotherapy, and they hear that from the beginning, they're more likely to actually enroll in the study. So I think that's one thing we're trying to emphasize. We know that there's not as much data out there as there was for Deborah. So Deborah, we have CLGB 9343, we have Prime 2, we have IGEA, we have Precision, we have all these trials, Lumina, that have suggested that in hormone-positive patients, it may not matter if we radiate or not. And we don't have as much data for HER2-positive breast cancers, but hopefully that data I showed you is convincing you that, this is a really great population to look at radiation emission. There's other countries that feel that this is a place where we need to look at radiation emission. So it'd be great if we are in that space as well and not just letting people in Europe do the study without us. And then again, the HER2 positive patients, less than 1% risk of recurrence in these early stage trials. So really, really a good space to look. I've had times when I've given these talks before, and radiation oncologists in the audience are like, you're taking away our clients and we're not going to have patients to treat. Why don't you just do partial breast instead of getting rid of radiation altogether? And so again, any radiation, there's still potential of toxicity. There's still risk of secondary malignancies. There's still a risk of cosmesis issues, and there's certainly financial toxicity. It's not free to do a PPI. So all those things as well. Think I'll stop there. I know I just chatted for a long time, but any questions from the group?
Well, I have good news. We just up to 80 patients enrolled.
Yay!
So I've
Okay.
already updated what I put in the chat.
Like 8%. Great.
So if anybody has any questions, we have a small enough group. Just feel free to unmute and ask your question, or if you don't feel comfortable with that, just put it in the chat.
This is Dr. Julian. I'm the protocol officer for this trial. And how many of you have the Deborah trial open and have the 008 trial open or are trying to get it open? Any response to that?
There's a couple people raising their hands.
For those of you who don't have both of them open, do you have, if you, I think we already asked this, but are you intending on opening BR008?
And we recognize it's harder to get patients on BR008. So we're just trying to see for those places who have BR007 open and they're enrolling like gangbusters, if there's any suggestions you all have to help us increase our BR008 enrollment. And some of it, again, we feel is probably just socializing this concept. People feel pretty comfortable with the hormone positive emitting because there's so much data to support it versus HER2. I think people are a little. Okay, so trying to enroll patients, just not many. Do you feel like the amendments are helpful? Does that expand your pool of patients?
Right, and the new amendments are out there. Hopefully they're being put through your institutions.
We have one question in the chat. It says, we at JFK Medical, we are trying to enroll patients. However, not many patients that qualify.
But
They
it
believe
looks
that
like
the
they
amendment,
did say the amendments help, so
yes.
awesome.
Yeah,
So hopefully it does.
Yeah, the new amendments may broaden that eligibility by tumor size and the use of radiation, which is standard at your institution, and also the use of neoadjuvant agents as well, which has been liberalized for HER2.
Dr. Chen, I know you probably have the study open. Any suggestions you have on how we can help institutions improve accrual?
No, I think the tumor size increase is a very wise one, mainly because it was difficult for a medical oncologist to see a early stage, 3 centimeters or less, and consider giving the upfront systemic therapy. And I think at our institution, we like the idea, just like Melissa had mentioned, of checking the response. So we're trying to favor the neoadjuvant arm, but obviously, I think giving the criteria of a larger size tumor, I think, is very helpful.
Awesome.
And the switch to a single agent, I think, will be helpful too. So,
Oh, that's good to hear.
Wonderful. Yeah, and like I said, hopefully we'll have our institutional report out soon for our 2-year results so that that'll help convince patients too to know that the preliminary data looks pretty good.
every time at our tumor board, I emphasize the excellent results of Dr. Tulane on the APT trial, and I say
Perfect.
that surgeons should not be hesitant to actually do the upfront surgery and then get the adjuvant HER2 therapy, but they're still reluctant. So
Yeah.
yeah.
Oh, well, keep trying.
Yes, thank you for supporting the trial and pushing so hard. We really appreciate it.
And,
Yeah, I think,
yeah, I was going to say sites, can look at it and say, well, we can get patients into the adjuvant arm, but not the neoadjuvant, or we can get patients into the neoadjuvant, not the adjuvant arm, and that's okay. If your site favors one arm versus the other, that's quite all right because they're independently randomized.
right. And I think now that Beaumont has merged with Spectrum Health, I don't think the West Side has even considered entering a patient or not. I'd have to check because we have now divided the state into Corwell. So the new name is Corwell. We're on the east side for Beaumont. On the Grand Rapids side, it's Huge Spectrum Health out of Grand Rapids. And I have to make sure that they're incorporated and they're aware of the new changes. So that may help. So,
And that'll be
and then,
great if you, sounds like that might have more potential patients for y'all too. So that's great.
Yeah,
and then
whatever,
obviously,
whatever works.
and obviously, I think most of the group knows that some of the radiation oncologists with Frank Vicini and Dr. Martinez broke off from our group, and they have an independent group called Michigan Health Professionals. So I think they're enrolling patients under their organization. So
Okay. Well, I know Dr. Vicini was the first enroller to BR008, so I know he's
right,
supporting.
he made it known to us that he was the one that first enrolled a patient. So
Yeah, Frank is a go-getter for clinical trials, obviously, all the way
right,
back with Sentinel node and with B39 and such. So that's quite good.
right. No, thank you very much, Melissa, for really pushing forward the new guidelines. I think that'll help.
Fingers crossed. Yeah.
So comments from any of the coordinators?
Leo and I are going to try to record a patient-centric video, which should be available. I don't know if any of you have, as coordinators, think, there was someone that recorded a 10-minute video, and in my mind, that was probably too much. So I don't know if you want to make suggestions on how much information something like that should share with the patient. Should it be short and sweet? Anything from today's presentation that I did that you think would be good for patients to hear?
Yeah, I raised my hand. I was actually going to ask. Oh, I raised my hand. I was actually going to ask if you wouldn't mind sharing these slides. I think it would be helpful to show the other studies that you've shared, and also to use as, training for all the physicians in our group.
Yeah, I know
Yeah,
usually these get posted, so.
Yeah, we
Thank
plan
you.
to post the recording as well as the slides.
Wonderful. Thank you.
Sure.
Yeah.
And then if you're not
Yeah.
aware, we also have patient materials that are posted on the NRG Oncology's website.
Yep, I
There's
saw those.
okay, great. There's a not a newsletter, I guess it's like a newsletter, and just a patient web page. And then I'm in the middle, almost completed updating the physician materials or for you to promote them and remind your physicians that this trial is still open. So when those get posted with the new amendment information, look for a broadcast that they're now available.
Right, and that material is almost always noted on the weekly broadcast and such. So stay tuned.
Anybody who would like Leo or I to come and chat via Zoom with their groups to try to promote the study? Anyone feel like that'd be useful?
I'll ask our PI, Dr. Hatum, if he's interested.
Oh, awesome.
And if you want to talk to your physicians first, you can always communicate that wish through the clinical coordinating department. And then we can get the message to Dr. Mitchell and Dr. Braunstein.
And I just thank you all for being supportive of the trial, trying to get patients accrued. Again, we want to do whatever we can to make it easier on you all and make patients and providers feel comfortable. So any suggestions you have, we're very open and willing to do whatever we can to help.
Any last minute comments or questions before we adjourn? Well, hearing none, we'll say thank you again. We hope this has been helpful. Look for the broadcast message that the recording is posted, and as well as the physician materials. And again, if you have any questions following this program, you can contact the clinical coordinating department, and I posted the email address in the chat. It's also in the front of the protocol.
And we all
Thank
thank
you.
you for being present.
Yes, thank you so much.
No, thank you.